Yep. Dr. Miao, please take over.
Okay. Thank you. So first, I want to thank this opportunity to introduce the Brain Science and Symptom Management Center. After the quick overview, I will turn it over to Dr. Martorella to describe several recent projects we just accomplished. And hopefully after our presentation, the ISL members and BSSMC members can know each other better, and we may be able to identify some collaboration opportunities in the future. And that's actually my hope. But anyway, today I will just talk about the type of work we are doing at BSSMC. Currently, Dr. Martorella and I are co-directing this center. And our #1 mission is to promote clinical and mechanistic research and use of the so-called non-pharmacological interventions. Our primary focus is the neuromodulation techniques in both the benchside and bedside settings. Now we are applying such techniques to pain management, aging, substance abuse, and mental health problems. And here we have the pictures of our amazing team members. So we also have Dr. Hani, Dr. Sokpor, and Dr. Chen. They are not actually all nurses. Okay, I'm not a nurse. Okay, I'm actually a data scientist and statistician by training. Dr. Hani is a psychiatrist, but you know, the rest of the team members are all nurses. I will briefly talk about the type of non-pharmacological interventions we're doing at BSSMC. We do actually mindfulness intervention, music therapy, cognitive behavioral therapy, and also the non-invasive brain stimulation. That's actually the focus of today. It's more related to the so-called digital medicine. We also do the combination of the above, and we also can deliver such interventions or therapies remotely to patients' home. So the kind of neuromodulation techniques we're using include TDCS and TASS. Actually, we are also working with Dr. Andy Kozo from College of Medicine. We have access to the so-called TMS technique, but let's just go over the TDCS and TASS first. So TDCS is the transcranial direct current stimulation, and the TASS is the transcranial alternating current stimulation. They're very similar, but TASS is just much more flexible. Here is the example system of actually TASS. So we have this box here. That's actually the signal generator. We also have a laptop connected with this box, so we can actually program the stimulation signal as we want. For instance, we can control the stimulation intensity. We can also control the stimulation frequency if we're using the TASS system. The stimulation signal will be transmitted to this cap. So this cap actually has lots of electrodes attached. So there's going to be some cables connect this box and the cap, so the stimulation signal can be delivered to the scalp of the subject. And then we use neuromodulation technique, neuroimaging techniques to measure or observe the brain response or activities. So that's a very simple illustration of the neuromodulation system. As I just mentioned, we also do lots of neuroimaging because this is important and necessary for us to measure brain activity and function in response to neuromodulation. We have the FNIRS, that's functional near-infrared spectroscopy, and the EEG, and also we have access to the fMRI through the College of Medicine core facility. So here's actually the picture of the FNIR system that's called the NIR Sport 2. It's quite portable. If you look at this head model, that's actually this model is made at the 1-to-1 ratio, and this is the FNIR's system. It's actually each box has 8 channels. So if you need more channels, just buy more boxes and connect them together. Okay, you will get a bigger system. So it's quite a flexible system. And also we have this EEG system. This one is much bigger because we actually get 96 channels in total. And also this one has the CAD, as we just saw in the previous slide. That's actually this CAD. So we can actually put the neuromodulation signals through this electrode, and also we can measure the EEG signals through such electrodes. So the two systems can be easily integrated from the hardware perspective. However, as to neuromodulation, there are two types of neuromodulation or non-invasive brain stimulation techniques. We actually are doing both, but closed loop neuromodulation will be our future. As you can tell that the open loop neuromodulation, which is simpler in both the hardware and the software system, the stimulation is delivered according to a pre-specified schedule without considering the temporal changes in the states of the organs or physiological systems under modulation. The problem is that open loop neuromodulation may fail to restore the desired function or sometimes cause side effects. So now I think more and more investigators are shifting toward the so-called closed loop neuromodulation. This kind of a technique requires more complex hardware and software systems. And we also need to develop some specific or tailored machine learning and AI tools to make this system to work well. The difference between the closed loop neuromodulation and the open loop neuromodulation is that the stimulation here is delivered when certain signals or conditions are met. And also we have the opportunity to dynamically change the stimulation parameters to optimize the stimulation effect in real time. So that's why it's called the closed loop. And in this way, we can control the effects or the adverse events as we want. But this system, we're still building this kind of system at BSSMC because we still don't have a mature machine learning and AI tools yet. But the plan is to get a prototype done by end of this year. So we can actually test this on some healthy subjects first, and then we'll move on to patients and do some real clinical studies. Here's an example of the closed loop neuromodulation system. Basically, our plan is just to integrate the TACS system and the EEG system together. We also do lots of clinical trials at BSSMC. We also have the capacity to take care of clinical trial design and data analysis. For instance, we have done many different types of clinical trials before, including single arm with external control study. And here the external control is more like EHR data. That's what Dr. Jahi is familiar with. And we do 2x2 factorial design. We do the group sequential or multi-arm, multi-stage design. And recently, we actually use the so-called smart design a lot. which is a quite interesting technique for precision medicine. And many investigators actually in the cognitive nursing are thinking about using this kind of design for their own study. It's very suitable for actually behavioral type of investigations. And also we are also developing some tools or methodologies to make this kind of design also suitable for other type of diseases, including aging problems and also cancer. Also, there's something called MOST design. You can just think about that smart design is the component of this MOST design. Okay, so it's called the multi-phase optimization strategy trial. It's also a type of trial that are going to allow us to identify the optimal dynamic treatment regimen. Anyway, we also have several funded clinical trials at BSSMC, and we are also providing various technical or analytical support to clinical trial studies. At BSSMC, we also have the expertise to do data science research and provide related services. Our expertise mainly focus on clinical trial, as I just mentioned, and also we have experience with the omics data analysis and EHR data analysis experience. We do lots of neuroimaging, like I just mentioned, and later I'm gonna also mention something related to the wearable sensors or mobile sensors. That will be another interesting direction we are trying to develop. And now I want to just quickly go over a few examples, okay, related to the data science research and services at the BSSMC. So here, this is actually the pipeline for FNIRS data processing and analysis. We're able to handle both resting state FNIRS and the task FNIRS. These two type of data are similar, but a little bit different because some of the pre-processing steps are the same, but at the individual level analysis, you have to do it differently. For instance, for the resting state FNIRS data, you will be kind of easier. You will do some, functional connectivity analysis. For each individual, you will quantify the connectivity network metrics to do the comparison. But for the task FNIRS, mostly we use the GRM model to do the estimation and perform some contrast test. And of course, for both type of data, we can do the group level, statistics and draw conclusions based on the population level. Here's another example for fMRI data analysis. So here I just visualize the skeleton of the pre-processing pipeline. There are many steps here. I won't be able to actually go over each step, but simply just want to show you that again, we are able to handle both the resting state fMRI and also the task-based fMRI. And this is the third example. That's actually the pipeline for the closed-loop neuromodulation technology. There are actually three main components in this pipeline. You see here labeled as A, B, and C. So this part is actually the signal generation component, and then here this is the AI machine learning component, and this one is actually the dynamic tuning component. Finally, I would like to mention the wearable sensors and digital biomarker studies we're conducting at BSSMC. So we know that when we do neuromodulation as a therapy, we have to, most of the time for our clinical study, okay, we need to actually bring the patients to our lab, or we need to send our equipment to the patient's home, so they can do the measurements. But once after we get the signal, the patients are away from the equipment, so we have no idea what they're doing, what's their daily activity or what kind of factors we're missing, what kind of information we don't know. Okay, it's just like a black hole to us. So we don't know why some people or some subjects respond well to our intervention, but some others patients they are just non-responders. Okay, doesn't matter how we tune the parameters. So in that scenario, okay, it becomes very important to have this kind of mobile or wearable sensor technology such that we can collect or monitor patients' physiological signals 24/7. Actually, this kind of sensor technology is from my collaborators at UT Austin. They're actually designed this kind of sensor products, very soft and thin as like a medical grade tape. So we don't use actually any glue. You simply just put this on the skin like here. This is actually a system to measure the cardiovascular signals. You just simply put on the skin, okay, the chest, and you will stay there for like 7 days. So you can actually get the signal automatically sampled and transferred to the cell phone. And we have a small app, okay, on Android and Apple cell phones, smartphones. So you can actually see the signals you received. And then we use the cell phone to temporarily store the signal. And then later we're going to transfer also these signals to cloud databases. So for some offline or online learning tasks. But anyway, this kind of sensors are, see here, they are very soft. So if you put in your hand, it looks like a piece of, very thin and soft fabric, right? So you will forget about this sensor, okay, after a few seconds. So it's totally like, you're wearing a t-shirt or, a robe or something. So it has a minimal interference with the patient's regular daily activity. Anyway, so this kind of the sensor technology we're using, and this is actually the deep learning framework we're developing. And we are actually, right now, we're at the stage of integrating this deep learning framework with the hospital system. So they can also actually use this kind of system in the ICU of a hospital. So that's actually the very quick overview of BSSMC. And now I think I want to turn it over to Dr. Martorella. I'm gonna stop sharing. Thank you.
Okay, great. Thanks, Hongyu. So let me share the screen for Dr. Martorella. So now it should be ready to go. So I'm gonna. Yeah.
The first part,
Okay. Yeah, you can just.
All right, can you hear me well? I guess so. Okay. All right, so thank you for having me. Thank you for being here. I want to present a few examples of projects that we completed or almost completed at the Brain Science Center. In all of the project, the long-term goal is really to facilitate equitable access to non-pharmacological interventions in order to rehabilitate older adults with limited mobility and resources. So because we're doing clinical trials, we'll still have to ask people to come to the lab to take measurement because we're using brain imaging or quantitative sensory testing. But the ultimate goal is to be able to offer flexibility in accessing those interventions. So we do offer, we do trial where we implement home-based interventions. So most of the, ooh, did I press something? Oh, okay. Most of the study we're recently completed, of course, we're interested in all kind of symptoms, but most of the study we're recently completed are related to chronic pain. So as you probably know, chronic pain is highly prevalent among older adults as parts of the aging process, and the number of people affected, it will increase with age. Of course, there's a lot of, it's a multidimensional problem that will lead to suffering, disability, social isolation, and of course, greater costs related to healthcare. So most of the time, pain will be relieved with medication. So and more realize across population, not only in older adults, that pharmacological treatment is not always very effective, and there's a lot of side effects. So there's a big push for non-pharmacological approaches, either to reduce the reliance on opioids or eliminate it if it's possible. So there's a big initiative from NIH to develop non-pharmacological approaches to reduce the use of opioid medications. So one of there's several processes involved in chronic pain, but what we've seen in the studies that we completed recently is a process that is related to what we call central sensitization. So when there's a repeated stimulation of the pain pathway, there's a sort of overreaction of the brain to the stimuli. And that's what we call central sensitization. So even if there's no injury, there will be pain. And it's a problem that is central in the brain. So that's why we're looking into those brain stimulation approaches more and more to be able to resolve the problem at the source. So the intervention we implemented recently were to reduce the overactive brain and overactive pain signals, and try to reset this heightened activity in the brain. So on the figure that you see, we have, of course, there's there's all kind of biological and psychosocial protective and risk factors related to chronic pain. Some are modifiable, some are not. And we're trying to mitigate chronic pain centrally by stimulating the brain. So in this way, we can improve the brain function in processing pain, but also increase the capacity in modulating pain internally. Like the body has this capacity to decrease pain. And of course, influence the clinical outcome of pain intensity and other symptoms. So the first project I want to talk about was completed with older adults with knee osteoarthritis. And we used a self-administered, so it was a home-based transcranial, so TDCS, transcranial direct current stimulation for pain in those patients. So they, most of them, of course, have chronic pain. It's a project that was started, if you have any question about the recruitment, it was started in Texas and then finished in Tallahassee. So we had different ways to recruit patients, but in Tallahassee, most of the time we work with TOC, so the Tallahassee Orthopedic Clinic, and also in the community in general. So we use the slow intensity, non-invasive brain stimulation, where we place 2 electrodes on the head, and you have this small current that passes between those electrodes. And you can decide the strength of the current, the duration, And most of the time, and of course, also the placement of the electrodes. So in terms of chronic pain, there are some guidelines that were published where they really recommend using a certain placement, so the motor cortex, and usually using 2 milliamperes in terms of intensity, and usually it's a session of 20 minutes. Most of the time it's 20 minutes once a day. There's some studies that will do it twice a day, but most of the time for our chronic condition, it's once a day. So it's something that we can use at home. We usually ask patients to come to the lab so we can train them, show them how to use the device, and they will do their first stimulation in the lab so we can really walk them through, and then they go home with the device, and they will have some appointments scheduled with them so we can walk them through the other sessions on Zoom. So as I said, there was older adults with knee osteoarthritis. The goal is to mitigate chronic pain. We had 2 groups of 60 each, 1 experimental group, 1 sham group. So in the sham condition, we use exactly the same device. It's just that we don't deliver the current. We only deliver it for like 30 seconds, and then we ramp down. So we don't deliver the full 20 minutes of stimulation. And so for this project, it was 20 minutes a day, 5 days a week for 3 weeks, so 15 sessions. In some other groups did 2 weeks. We tried 3 weeks to see if we had a sustained relief at 3 months, because most of the studies will look at post-treatment, but they don't have a long-term follow-up. So this is the study flow. I guess we're really good at keeping in touch with people because we don't have a lot of dropout or withdrawal. And I guess having those scheduled appointments helps a lot. So the mean age was about 66 years old, mostly female, African-American and white patients mostly, and married. So most of the time those people are retired, not working. They had the same, about the same level of pain when they started the trial. So that's the NRS that you see at the bottom, numeric rating scale for pain intensity. This one is the 0 to 100. So that's why you see mean scores of 50 or 55, which would be on 0 to 10 would be 5 or 5.5. The WOMAC is a questionnaire that's specific for osteoarthritis symptoms. They will look at pain, stiffness, and physical function. So the result, we saw a significant reduction of pain intensity up to 3 months in the experimental group compared to the sham group. We also measured a pain modulation capacity, so what we call quantitative sensory testing. The way we do that, we use another, so it's not brain imaging, it's really looking at tolerance to cold, tolerance to heat, tolerance to pressure, and there's a calculation to figure out what is what we call conditioned pain modulation. So we use experimental pain related to cold, heat, and pressure to see if the person is able to modulate pain better than before having the intervention, basically. So we also saw an improvement in the pain modulation capacity. Okay, so we still had a lower pain level. If you look at the figure at the top, that's the pain intensity. We still had lower level of pain at 3 months compared to the other group. But we see that it's going back up. So that's something I want to talk about because that's what we want to look at in the future. So the effect will subside with time if we stop the stimulation. So participants showed high levels of satisfaction with the treatment. It was with using the device, they didn't, maybe the first session, well, they needed more supervision, but after that, they found it easy to use. There was no adverse events. And as I said, the effect, so the pain relief will subside with time. So now a next step would be to look at extended therapy. So what if we do those 3 weeks with 5 sessions, 5 sessions a week, and then we do some kind of boosters where we'll keep a stimulation once a week for 3 months and see what happens 12 months after. Do we still have an effect or not? We also want to look at responders and underlying mechanisms. So in this study, the experimental group had a significantly reduced pain, but we only had 60% of responders to treatment in that group. So those are questions we want to answer. Can we obtain sustained relief by extending the intervention? Why do some people respond better to TDCS? And do we observe more responders when we extend the therapy? Oops, I wanted to move Hongyu from my slide. Sorry. Okay. So as I said, we worked on chronic pain, but there's other conditions that are being studied in conjunction with TDCS. So you have, of course, mental health, depression, substance use disorder, other type of chronic pain conditions, attention, cognitive impairment, and motor rehabilitation. Okay. Another study where we used the same TDCS device, but it was a pilot study with 40 patients who had dementia, Alzheimer's disease or Alzheimer's disease and related dementia. So it was a pilot study so we didn't do 3 weeks. We only did 1 week, 5 sessions, and then look at post-treatment results. So we recruited people with early stage dementia. They had mixed conditions of chronic pain. So there are some studies that are looking at the relationship between developing chronic pain and having dementia. Which one comes first? There's definitely a correlation between chronic pain and cognitive decline, but it's still unclear the pathophysiological mechanism. But because it's a population of older adults, they will also have other causes of chronic pain. They could have osteoarthritis, for example. So there could be either chronic pain related to the cognitive decline, the Alzheimer's disease in general, and also other chronic pain conditions. So same thing, we had 2 groups, experimental and sham TDCS, 20 in each group. It was also remotely delivered. We asked to have a caregiver available for the sessions. And so 20 minutes, 5 days a week for 1 week, 5 sessions total. And this is the study flow. And I think in this study, what was really helpful is to have a caregiver that was committed to the study. So that would help with the adherence to the intervention. So mean age was a little bit higher, mostly female again, and white participants and married. So we saw a reduction. So we took 2 different measures of pain intensity. One that was the regular NRS that was administered to the patient, and the other one is a measure of pain that we use in caregivers. So what do they think the pain is for the family member? So we had a reduction on both of those measures, no adverse events. And of course, because it was a pilot study, we want to replicate the study and conduct a large-scale RCT to validate the effect of TDCS in this population. Yes, I was just gonna say that TDCS is widely used in this population for cognitive decline already. So we were cautious by doing only 5 sessions to start, because of course we want to see if we're have an impact on pain. But I've seen study where they use TDCS for 12 months in this population. They actually saw a decrease, a slowing of the cognitive decline and the progression of the disease. So which was very, very interesting, I find. So we didn't take any, this study was only subjective measures. We didn't use FNIRS or quantitative sensory testing like the previous study I just presented. One second. Okay, so this study, a little bit different. We only did mindfulness based intervention. The idea was that we see, so mindfulness-based intervention in general are 8 weeks long for chronic pain patients. But we have seen recently some briefer interventions for preparing patients for major surgeries so in the preoperative phase. So they will implement a brief mindfulness intervention before surgery, and we see a decrease of a decreased pain and decreased opioid use in the first few days after surgery. My concern was that again, to be able to prevent chronic pain. So those patients have their surgery, their pain is very well managed while they're still in the clinical setting, in the hospital, and then they're discharged home with a prescription of medication. And we just let them manage their pain on their own. And then they have a follow-up with the surgeon 2 weeks after, then I think it's 6 and 3 months or something like that. But there's nothing very specific to help them manage their pain. And we see in the studies that some people are still taking opioid medication 3 months after their surgery. There's they will ask for a renewal of their prescription. So really what's going on in this phase after discharge? And you realize there's not a lot of studies about pain in this post-discharge phase. So that was my concern. I said, well, chronic pain usually is after 3 to 6 months, and the recovery period is 6 weeks after surgery. Can we prevent the development of chronic pain in this phase? And also, can we prevent opioid misuse in this phase? So that's why we implemented an online brief mindfulness-based intervention after discharge. So it was about a week to 2 weeks after surgery. They were starting the program. It was a weekly, so it was 4 weekly sessions of 30 minutes. Of course, it was a pilot study because, again, it was a first trial. And we had, so 2 groups, experimental, active control. The active control group received standardized pain coping education. And it was a brief adaptation of a very well-established mindfulness intervention. So we delivered the intervention asynchronously. So there were recorded sessions that we delivered via Qualtrics. And like I said, 4 weekly session of 30 minutes after discharge. All right, this is the study flow. So we ended up having 18 patients in each group, sorry. So mean age for the entire sample was 66 years, mostly married female. Again, they love participating in clinical trials. Married, and most of the patient had total knee replacement. I also had some patient that had total hip replacement. They also, of course, because they needed surgery, they had chronic pain, and they were involved in a rehab program after surgery, so most of them. We had a slight difference between the group before the intervention. So the experimental group had slightly higher levels of pain intensity and pain interference. So pain interference with activities such as walking, sleeping. There's different enjoying life. There's both emotional and physical function in the pain interference measure, and also a little bit more anxiety. So what we saw right after finishing those 4 weeks of intervention, we saw group by time interaction. So there was a difference in pain intensity between groups and pain interference in favor of the experimental group. And also we observed a trend towards using less pain medication in the experimental group. So I didn't record how much in milligrams of opioid were consumed, but I did ask the patient, are you still using opioid? Are you using OTC? Are you using both? And so there were less use in the experimental group and also less opioid use. So over 80% of the experimental group experienced at least a 50% decrease in pain intensity, and only 25% as opposed to only 25% in the control group. We also had observed that 56% of the experimental group was completely pain-free after the intervention, as opposed to only one participant in the control group. And we didn't have, so of course we measured pain acceptance, pain catastrophizing, and mindfulness because it was an intervention targeting those psychosocial factors, but we didn't see any effect on those measures. So again, I would like to conduct a large scale efficacy study for this intervention. So lastly, I don't have any result to present, but just to show you how we're building on the knowledge we had with those previous studies and coming with new ideas. So what if we combine brain stimulation and mindfulness or meditation? There are some studies that say that we will optimize the effect of both intervention by combining them together. So I was really interested in seeing if we could have an effect on pain relief after surgery if we do something before, because usually we use TDCS like most studies, they use TDCS after surgery, but what if we do it before, because they already have chronic pain, they have central sensitization, because they have knee osteoarthritis. So what if we decrease chronic pain before surgery? Can we have an effect after? And it's the same principle as giving preemptive analgesia. So you give pain medication before surgery, so it's less painful during the procedure and after. So we just, and by the way, this is a study that was funded by ISL. There was just some delay because we moved during the study, the center moved and everything, so we're kind of late, but we're about to analyze those results. So we had older adults undergoing knee replacement surgery. We want to mitigate acute postoperative pain by implementing an intervention before. We had 2 group, experimental and sham, and it was a combined intervention that was, so it was simultaneous, where they were receiving brain stimulation and listening to a meditation for the 20 minutes that they were receiving the brain stimulation. 5 sessions of 20 minutes, remotely delivered before surgery. So the next step would be really combining those interventions before and after. Like I just told you about the mindfulness intervention after discharge. So what if we do something before surgery, after when there's discharge? Do we see a decrease in the chronic pain development and also medication or opioid use? And of course, looking at underlying mechanism of each intervention and the combination of those two interventions. Thank you.
So, anyone on Zoom?
Hongyu, do you want to add anything?
No. Wonderful talk. I just want, take questions if you have any.
Yeah, so for those on Zoom, please feel free. I'm just gonna probably stop sharing. So if you have any questions, please feel free to ask. Both Dr. Miao and Dr. Martorella are both here. So I think a lot of I think if you look at numbers, I think some of our attendees are from the community too, so they might be interested. Yeah. So I actually have a question for Bill. So Bill, do you think that there will be an opportunity for collaboration because you are also healthcare provider? Do you have any patients potentially could benefit from interventions for pain management like this?
I definitely think that there's a possibility that we could look at our palliative care program where we're experimenting more with chronic care management right now. So there's a possibility that we can look into that. I don't know of anything right off the top of my head. And our medical director, our chief medical officer, excuse me, is at a conference in Denver this week, but she'll be back on Friday, I believe. So I'm definitely open to having that discussion, and I'm going to have to jump off this call, but I really appreciate the presentation. It was really very insightful. So thank everyone who presented, and yeah, let's talk about this next week.
Thank you.
Thank you so much. Yeah,
Absolutely.
thank you.
This is Connie Joyce. I've got a question.
Yes.
Are y'all looking at long-term, excuse me, pain management? Like I suffer from stage 4 cancer. I take a very low dose opioid when needed for pain. And it's probably, I mean, I'm going on 3.5 years. So it's going to be something long-term probably in my life. Is this something you're looking at that you could do for, someone could do it for years, possibly to not have to do an opioid for pain?
So it's not something that we have done, but I've seen studies where they use TDCS on long term and even TMS on the long term for as long as 12 months. I haven't seen a use of brain stimulation over 12 months, but that's definitely something we want to look into because I presented the result for knee osteoarthritis. It's very interesting because we had this reduction of pain, but if we don't have this relief after 3 months, there's no point. So we want to definitely try to extend the intervention and see if we can have a longer relief, and maybe we can get surprising result where we'll actually don't have to do any boosters after a while. Well, we don't know exactly. That's why we need to see what's happening in the brain, because if we're able to do like a reset of the pain processing in the brain, then we could have a long-term effect. But that's something we haven't done yet, but we want to definitely, because we're looking at chronic pain. You need to have long-term relief.
Okay, thank you, and thanks for the presentation.
Thank you.
Last one thing to add, actually last year, Mayo Clinic actually come to visit FSU, and I had the opportunity to talk to them. They also have a group that are interested in the cancer pain management. And the idea actually is more like not using TDS or TSS alone, but combine TSS or TSS ways that, that pain pills. Okay. So together, we might be able to, reduce the dose of the, chemical compound consumption. But you know, still have their pain controlled under certain, you know, tolerable threshold. So that's kind of the idea. I remember. But anyway, right now, my personal opinion will be like, you know, I believe that TDS, TSS that have long-term effect, but probably for cancer pain management, we have to combine that with, you know, the regular pain control pills.
I have a question here in the chat. Who at TOC has this information? Can you clarify the question? What do you mean? It's renowned. So I'm not sure.
Yes,
Yes.
I have chronic pain and I would love to be in one of these studies or access this pain and modulation, you know, with the brain stimulation. I do go to TOC a lot. So I wondered if there was someone at TOC, maybe Dr. Chandler in pain management or someone that would be
Yes,
doing this.
See Dr. Wang there or
well, Doctor, I've worked with, because I did so I worked with Dr. Wong and Dr. Bellamy, but Dr. Chandler I know him and he knows about our work. So the intervention is not available because it's still an experiment. So it's not available as an option that you would just come into TOC and I want the brain stimulation intervention. But definitely if you're interested in being part of the study, then we could keep contact information, or you can reach out to, we could use, actually, we didn't give the website address of the BSSMC, or even via the ISL, because we're always, of course, looking for participants. So that would be, we'll gladly involve you in one of those studies.
Okay. I'd love to be involved in one of the studies. I've done other volunteers at FSU. So
thank you.
yes.
Actually, there's also another study recently I found out. It's more related to the aging problem. So actually, some investigators are also using TDSS, TSS to help elders to reduce the risk of falling or control the risk of falling. So that's another thing. You know, whoever is interested, we can, you know, talk about it later.
So how can we sign up to be called for possible studies? Where would we go?
You have, would it be through ISL? Or?
Yeah, you can, we will actually start putting up like a website about our ISL supported studies, not really supported, but like ISL studies that are related to aging research.
Okay.
So you can go to the website. I mean, we haven't put up the web page yet, but we're gonna create that web page, and then we'll send an email to the communities, like as if we are sending the email to everyone for this work for this webinar, so they can see what studies are looking for participants, and we can reach out to the PIs.
And maybe as a follow-up to this presentation, we can also circulate the website address of the center.
Yeah.
So if you need to contact us, you have everything on the website.
Mm-hmm.
Thank you.
Thank you for the interest. Thank you so much.
All right. I think in the interest of time, I think we can probably close our webinar today. And certainly we're gonna send you news about ISL studies and also the upcoming events from us. And if you have any ideas that you think ISL can help you for aging-related problems, certainly please feel free to reach out to us at isl.fsu.edu. And certainly, I think this webinar is great because we have people from the community actually asking questions about this intervention, how it can really help you. That's really great. That's exactly what we want to achieve with this type of events. Thank you so much, Hongyu and Geraldine, for sharing so much with us and be with us today. And thanks everyone for attending. I'll see you next time in our next webinar event. We also have the professor from Dr. George Demaris from University of Pennsylvania coming to Tallahassee on October 9th. We already sent email to everyone, so please sign up for that event if you're available. Thank you.
Yeah.
See you everyone.
Thank you.
Mhm.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you. Bye-bye.